It's finally nice to see you. It's good to put a name on a face after all the communication that we've had.
Absolutely, sir. How have you been? Everything good?
Not too bad, not too bad. Still living with the pandemic like everybody else.
I know, variants after variants after variants, right?
Yeah, that's the new world.
I know. Living with COVID has become the new normal.
Yeah, we're gonna have to, I think, learn to live with it for a while. So you just have to modify life and study and everything else that we do into this new world.
That's right. That's right. You got it right.
How are things at your end? Are you able to get medical students into classes, bedside teaching?
It's a bit of a challenge. We have been trying to do that in small batches and stuff, but then large groups we are trying to mostly avoid, especially with the Omicron variant becoming extremely rampant in our country slowly. So yeah, especially this month and next month, we are expecting a peak. So we have reduced the number of live classes and again, trying to go back to the online mode.
Yeah, that's, I think, happening worldwide at the moment.
That's right.
We are ramping down as well for our medical students, but I suppose it is what it is. Can't do much about it. Can I actually just see if I can share my screen just to make sure things actually work out, and maybe you and Justin can tell me it's actually working?
Yes, sir. Please do it.
Okay, let me just see. It is what it is. Can you see my full screen? Just see if I can share my screen just to make sure things actually work out, and maybe you and Justin can tell me it's actually working.
Yes, sir. Please do it.
Okay, let me just see. All right. Okay, so that works. That's good. Great. All right. Jacob, I just emailed you about the title because I think there was some confusion about the title change for the talk. Just to make sure it's actually work out, and maybe you and Justin can tell me it's actually working. Okay, so that works. That's good. Great. All right. Jacob, I just emailed you about the title because I think there was some confusion about the title change.
Sorry, something is wrong. Look at it.
Because I think there was some confusion about the title change.
Hello, Dr. Jacob. Dr. Jacob?
Yes, yes.
It seems to be slightly better now.
I will try to mute mine.
Justin, how long, or Jacob, how long is this talk for?
I think you're allowed to take 45 minutes to an hour.
For 1 hour?
Yeah, 45 minutes.
I see. Okay, I think that's good. Yeah, I planned for that. I just want to make sure that it's still the same timeline. Great, thank you.
I will try to നമ്മൾ സംസാരിക്കുന്നത് വീണ്ടും വരും ഞാൻ സംസാരിച്ച് കഴിഞ്ഞത് വീണ്ടും എവിടെ നിന്ന് റെക്കോർഡായി വീണ്ടും പ്ലേ ആവുന്നു ഇത് കണ്ടോ ഇത് ഞങ്ങൾ സംസാരിച്ചു
Okay, I think that's good. Yeah, I planned for that. I just want to make sure that it's still the same time. Great, thank you.
നമ്മൾ സംസാരിക്കുന്നത് കേൾക്കുന്നുണ്ട്
Okay, I think that's good. Yeah, I planned for that. I just want to make sure that it's still the same time. Great, thank you.
നമ്മൾ സംസാരിക്കുന്നത് കേൾക്കുന്നുണ്ട് ഇത് പ്രശ്നം ഏത് കമ്പ്യൂട്ടറിലാണെന്ന് അറിയാം
Jacob, is it better now?
Did we do something over there? Is this corrected?
Okay, maybe the volume this side was high. Yeah, maybe an echo. So maybe we can start.
We do something over there. The delay is there. There's some sort of a delay. I don't know from where this is coming from. Is this corrected?
Okay, maybe the volume this way was high.
What we can do is we'll make Dr. Justin the host and we'll switch off this computer and we'll see if it works. Is that fine? What we can do is we'll make Dr. Justin the host and we'll switch off this computer and we'll see if it works. Is that fine?
Hello? Hello? Dr. Samana.
Are you ready? Yes, I can hear you, Justin.
Sorry for that. It was the error from our main system. There is a mother system. There was some sort of a recording and replay error, I guess. We have not yet sorted it out. So we have resorted to, do all the work from this system itself. So I think it's working now.
Oh, okay. So could I share my screen?
Yeah, just do it now. We can see if it works.
All right. So you should see my full screen now, Jacob.
Yes, we can see.
Great.
Can you try moving, sir?
Sorry, I couldn't hear you there.
Can you hear me?
I can hear you now, yes, but it's just a bit fuzzy.
Yeah, can you try moving the slides, changing the slides? Yes.
Is that working? Yeah.
Yes, it's working. It's
Great.
perfect.
Great.
Okay,
So are we starting?
Now you can unshare. We will start the program and then we will hand over the session to you.
Oh, okay. So I'm going to stop sharing them.
Yes.
All right.
So it goes like this, sir. I will welcome the gathering and we will basically from this meeting, we will not have much participants in this meeting, but from this it is being live streamed onto the students. Okay. So they'll be in the classroom. So they'll be listening from there. So yeah, so what we do, I start the program and then I introduce the moderator and hand over the session to him. So he will introduce you and give an overview of the topic and hand over the session to you. Once your talk is over, Dr. Justin will take questions and hand over the question to give the questions to you, and we will have discussions, and then later on we will close the program. I will close the program. Is that okay?
That should be fine, yes. As long as we finish by 8:30. I'm on a tight time schedule for today.
Yeah, sure. We'll do it fast, sir. We'll do it fast. Yeah. So.
Great. Do you want me to share my screen again, Jacob, or no, not
sir,
yet?
I'm going to start the program.
Okay, so let me know when we need to do that.
Dr. Justin will hand over the session to you.
Sure, that'd be fine.
Okay, thank you. Good evening, everybody. Welcome to this 78th International Webinar at Believers Church Medical College and Hospital. Today, the title of the talk is The Metabolic Outcomes in Childhood Brain Tumor Survivors, Current Challenges and Opportunities. To give an overview of the topic and to introduce our international speaker, we have with us our young and dynamic consultant endocrinologist, Dr. Justin Sam Izzo. After training from the prestigious MOSC Medical College and also from the Ramaya Medical College in Bangalore, India, he went on to work at the Bangalore Baptist Hospital and is currently with us as the consultant endocrinologist. So it's a great pleasure to hand over the session to him, and he will take over from here. Over to you, Dr. Justin.
Thank you, Dr. Jacob. I am thankful for this opportunity, and I consider it my privilege to be the moderator of the first international webinar of this year. Brain tumors are the most common solid neoplasms that occur in children. And over the past 20 to 30 years, major discoveries in the tumor biology and advances in the diagnosis and therapy have significantly improved the survival rates of these children, with the mainstay of the management being a multimodal approach of surgery, radiation therapy, and chemotherapy. But even as the number of survivors have risen, it has become evident that this group is at risk of developing chronic morbidities and premature mortality. For example, it has been clearly shown that in spite of a similar BMI, childhood brain tumor survivors have increased adiposity as compared to non-cancer controls. And this could translate to increased insulin resistance, glucose intolerance, and subsequently increased cardiovascular morbidity and mortality. Why does this happen, and what could be done to address these issues? So, to speak on the topic metabolic outcomes in childhood brain tumor survivors, we're delighted to have Dr. Constantine Saman as a speaker this evening. Dr. Saman is an associate professor, Department of Pediatrics, McMaster University, staff physician, Division of Pediatric Endocrinology, McMaster Children's Hospital. He has established and leads the pediatric and adolescent type 2 diabetes program at the same hospital. He is also the director of research and scholarship at the Michael G. DeGroot School of Medicine. Dr. Saman is the leader of a transnational research group with focus on defining mechanisms and designing interventions to treat and prevent childhood obesity and diabetes. So for the next 1 hour, Dr. Saman will speak to us on this topic, and after that, we'll have the question and answer session. Over to you, Dr. Saman.
Great. Thank you very much, Justin and Jacob, for organizing this meeting and for inviting me and for the kind introduction. I'm delighted to be here to share with you the work that has taken place over the past several years to clarify the metabolic and endocrine outcomes for survivors of childhood brain tumors. I'm going to start sharing my screen now. So can everybody see my screen? Yes, great, excellent. So from our end, I work at McMaster Children's Hospital in Ontario in Canada. And this is a picture of the building. We are a tertiary pediatric care center, and we serve around 2.3 million people. And that is roughly around 7 to 8% of the whole Canadian population. So we are a large center. We take care of children with a variety of endocrine disorders. And one of my area of interest is pediatric populations that are at high risk of obesity and diabetes. And today I'm going to be speaking specifically about the survivors of childhood brain tumors, which is an important part of the work that we do. I do not have any conflicts of interest to declare. And the objectives of today's talk is to describe the occurrence of diabetes in survivors of childhood brain tumors, look at some early risk markers for diabetes in this population, and try and examine any potential interventions that we may have at our disposal at the moment to try and mitigate the risk of diabetes and in this population. And so I wanted to start sharing with you a case that I have been dealing with. This was a 12-year-old girl who was referred to our clinic from the neuro-oncology program for management of obesity. And the weight was quite significantly elevated, as well as the BMI. The mother has history of type 2 diabetes, and the patient was hypertensive. And in the world at this point in time, of course, we are dealing with a significant number of children who are overweight or are living with obesity. And this patient had an added problem, which she had to deal with a brain tumor in the early years of her life. Now, the number of patients with diabetes, as noted in the International Diabetes Federation Atlas last month, is projected to rise by about 46% in the coming 20 years. And this rise is universal. Every continent on the planet is having that increase. And if we look at different places, for example, in North America, we're expecting a 24% increase. But in other parts of the world, for example, in the Middle East and North Africa, these numbers are going to rise by 87%. In Southeast Asia, these numbers are rising by 68%. And that tsunami of cases is, of course, something that the healthcare systems will have to grapple with. And in the pediatric population, survivors of childhood cancer has emerged as one of the populations that are at risk of developing diabetes later on in life. Now, I don't have to tell you that obesity is a global epidemic, and you can see in this chart that rates have been rising over time. On the x-axis, we have years, and you can see that the rates actually have been rising over time in all domains and around the world. And this is related, of course, to multiple factors I'm not going to be speaking about today. But obesity is a global epidemic, and it's one of the main drivers of type 2 diabetes, of course, in the world, but it's not the only one. Now, this is old data, but what it shows us is that obesity rates in the pediatric population, in fact, have plateaued in the high-income countries. They remain a serious problem in low and middle-income countries. But if we look at the data from the GENA study, which is a cohort in Germany that has been following children for the past 100 years, the rates are, in fact, started to plateau around here. So this is a problem that continues to be significant, but in the high-income countries, actually, the rates are starting to slow down. And I wanted to share with you some ideas about actually the prevalence of type 2 diabetes in children. And what you can see here is, again, this is recent data from the International Diabetes Federation Atlas. You can see that not all countries of the world are represented here. But the thing I wanted to highlight is that indigenous populations in Canada have some of the highest rates of type 2 diabetes in the world. And this data is not even new. It's almost 5 years old at this point. And the rates are projected to have increased around the world. And again, we are, of course, trying to capture the global scale of both the type 2 diabetes and the obesity problems in children and understand their impact on a future cardiometabolic risk. The incidence of type 2 diabetes, of course, again, is rising in children, and Canada has some of the highest rates of this condition as well. And it is important to know that whatever number I give you today for type 2 diabetes in the world is probably an underestimation. Up to 50% of people with type 2 diabetes do not know they have it because they've never been diagnosed with it, and they don't feel symptoms and they don't have signs of type 2 diabetes. But it is projected that about 10% of the world population will have type 2 diabetes over the coming 2 decades. The numbers are rising in every country, and the greatest number of people who are developing this disease are in their middle age. Around 20 million children are born to mothers who have diabetes, gestational or pre-gestational. And those children have several-fold higher risk of developing type 2 diabetes, obesity, and cardiovascular disease later on in life. So as you can see, the scale of the epidemic is significant, and it's happening because of a multitude of factors. Some of it is lifestyle related, some of it is genetics and epigenetics, and some of it is environmental. And it's a very complex mix for healthcare systems around the world to deal with, of course. Now, we got interested in looking at the outcomes of childhood cancer several years ago when in a collaboration that used a database that looked at 6,000 children who have survived the brain tumors over a 40-year period. And we published this several years ago now, but we were interested in is to see whether the survival of these children has been changing over the past 3 decades, because the advancements, again, in treatments and interventions and screening had indicated that a significant portion of these children are surviving. And in this study, what you have here on the x-axis are years from diagnosis, and on the y-axis, we have the relative survival ratio. And what we can see here, regardless of the age group, you can actually survival progressively declines over time. And around the 30 to 35-year mark, about half of these children would have actually passed away. And this was a very significant revelation to us, because all these advances at the start, when we actually cure the brain tumor, are clearly leaving a burden. And that burden on these children is translating into premature mortality. The oldest person in this database was actually 59 years old. And so that got us thinking about, why are these children dying prematurely, having survived a life-threatening illness? And these children have also been shown to develop type 2 diabetes at a higher rate. And in this study from Scandinavia that looked at almost 8,000 survivors with a median time of follow-up of about 10 years and a 1-year survival period. The study looked at hospital admissions as a surrogate marker of type 2 diabetes, but what identified is that there was about a 2-fold higher chance of a survivor of a brain tumor to have type 2 diabetes. And interestingly, actually, there was also a small increase in type 1 diabetes. And we don't really understand the autoimmune component of diabetes in survivors, but certainly in the type 2 diabetes population, we can see there's about a 2-fold increase in type 2 diabetes. Sondra Chen, who is currently a medical student, did this work when she was an undergraduate within our researcher group, and she's continuing to work on this paper that has demonstrated that survivors of childhood brain tumors have actually, survivors of childhood cancer, including brain tumors, have actually a higher risk of developing type 2 diabetes. In this graph here, which is we call a forest plot, we have the percentage of the odds ratio of children developing type 2 diabetes, and on the y-axis we have the studies that reported this. There isn't a whole lot of evidence, but type 2 diabetes in survivors of childhood cancer occurs about 4-fold higher, and the risk of type 2 diabetes versus type 1 diabetes, again, is 4-fold higher. Now, this data is quite similar to the data that we are seeing from the Scandinavian data. But also this, of course, highlights a gap in our knowledge as to why do children who survive cancer actually develop type 2 diabetes. And in this study, looking at the long-term causes of death in childhood cancer in general, what was known is that children who survive cancer in general would develop either a recurrence or a progression of their disease, or they can develop a secondary cancer. And what was interesting is that as time went by and as survival increased, and as children started to live longer, what you see here is that circulatory disorder, cardiovascular disease, accounts for about 1/3 of the mortality in this population. So it's not only about the cancer and its treatment that are causing problems. Survival itself has added its own burden, and cardiovascular disease, of course, has become a major player. Now, one of the major drivers of cardiovascular disease is type 2 diabetes. And what I've showed you so far is that there's a higher chance of developing type 2 diabetes. This may contribute to the higher risk of cardiovascular disease. And then the combination is probably affecting long-term outcomes in this population. Now, the question we have asked really, do children have higher rates of obesity when we compare them to controls, because we know that obesity is a major driver of cardiovascular risk and of diabetes risk. So we asked the question, do children who survive brain tumors actually have higher rates of obesity compared to controls? And this is a systematic review that Catherine Wang did when she was doing her master's degree with me. And for those who don't know systematic reviews, I'm going to just describe this first diagram to help orient the audience. What we have here is a method that can summarize systematically all that is known about a researcher question. In our case, it was the prevalence of obesity in childhood brain tumors. And what you see here is the first column will describe the outcome. In our case was overweight or obesity. You will have the names of authors. These are the studies that was used to extract the data. We pulled data on the prevalence here with a standard error. We also then assign a weight for each study, how much each study is adding to the weight of the evidence we're using. And then we report the prevalence with a 95% confidence interval. This data then is translated into a diamond or a box. We call this right side of the graph a Forrester plot. And in the Forrester plot, you can see diamond sizes. The size of the diamond or the square is dependent on the percentage or the prevalence that you have. And then the diamond here actually summarizes the data from the individual studies. So the size and the scale of the diamond, as you can see, for example, if you compare the top to the bottom, you can see the diamond size goes up as the percentage goes up. So I hope this is helpful just to orient the audience to a systematic review readout. And I focused here on obesity just to make the point that when you look at non-cancer controls, the rates of obesity is around 1 in 6. So about almost 17% of the non-cancer controls in this paper that we did were overweight, were obese, in fact. And we then split the brain tumor group into two groups, including a craniopharyngioma group and non-craniopharyngioma group. Craniopharyngioma is a brain tumor that is associated with hypothalamic obesity. We know that those kids become overweight. What we're interested in is not only the total population of the brain tumors, but we really wanted to understand whether non-craniopharyngioma brain tumors, which are several groups, would have the same problem. And what you can see here, if you recall that number that I shared with you for obesity, it was about 17%. When we look at the non-craniopharyngioma group, they do not appear to be more overweight or more obese than the control group. The rates of obesity are the same. While if you look at the craniopharyngioma group, more than half of them are actually obese. And that then, if we compare this group, the non-craniopharyngioma group, to the controller group, you can see that actually using the BMI Z-score as a measure of obesity in children doesn't really tell you much about the risk of obesity. The two groups have the same rates of obesity when we compare them. And this is separated from the craniopharyngioma, a group that is well known to have overweight and obesity. So for the remainder of the talk, I'm really focused on the non-craniopharyngioma brain tumor groups, because that's the group that is really fairly interesting in the phenotype that we detected. Now, in conclusion for this part of the talk, survivors of child brain tumors have a higher risk of developing type 2 diabetes, and those about 1 in 6 of them only have obesity. So the next question we wanted to understand is whether actually the body mass index is a good measure of the fat mass in children. As you are aware probably, that adiposity or an excess fat mass, especially central or visceral adiposity, is one of the main risk factors for cardiovascular disease and diabetes. People who have an excess central fat with a high waist ratio, waist to height ratio, waist to hip ratio, are at higher risk of developing cardiovascular disease and diabetes. So we wanted to understand whether actually BMI, which is the most widely used clinical measure in pediatrics, and I should say BMI Z-score, is a good measure of the fat mass in children. And do children who survive brain tumors have higher adiposity than controls? So in our work with another group in Canada, we are part of a large cohort study that is national, that is examining outcomes of children who are living with type 2 diabetes in the country, we used DEXA scans to compare the fat mass detected by DEXA scan against the BMI Z score to see whether actually BMI can predict the fat mass. And as you can see from the right side diagram here, BMI is actually not a very good measure of the fat mass in children. It might be a good measure in adults because adults do not grow anymore. There's no change in their height. But actually in children, it is not really a very good measure of the fat mass. And the challenge with that, of course, we all use the body mass index Z score as a measure of obesity, and we translate that into a risk of adiposity. But that's actually not true when we look at our data. One of the clinical indications that we have used recently, and we've reported this in several publications, is something called the Tripondral mass index. And the Tripondral mass index is weight divided by height to the power of 3, unlike BMI, which is weight in kilograms divided by the square height. And this measure, in fact, takes into account that children grow in 3 dimensions, and it accounts for their height change as well as their weight change as they grow. And we can see that the Tripondral mass index is a clinical measure. It uses height and weight as well, but it actually correlates fairly well with the fat mass percentage that we detected using DEXA scans. And so we do believe that this measure may be actually a better measure than the body mass index Z score in children, and we've seen that in type 2 diabetes, but it's also been shown in the general pediatric population. And I'm here just reporting on the association, the strong association of the Tripondral mass index with the fat mass percentage, as we can see from the p values, but actually also to predict central adiposity fairly well. Now, the differences here, of course, are when you compare it to the BMI, it's a little bit better, but the advantage for it is actually it targets adiposity specifically. And we feel that this is, in fact, a very important advantage of using a clinical measure to measure the fat mass. So when we look at this population, the question we asked in our studies, if we compare the survivors of childhood brain tumors to controls, do they actually have higher adiposity? Now, I showed you data that suggested that actually when you use the BMI Z score to measure obesity, the non-craniopharyngioma group of brain tumors survivors have exactly the same body mass index Z score. And so what we wanted to know is whether this population have higher adiposity rates. And of course, just a primer on adipose tissue. Adipose tissue is stored at different compartments in the body. And until recently, people were thinking about it as merely a sink for calories that we consume. But of course, the role of the adipose tissue has evolved considerably over the past years with a new realization of its biological functions. And we know that adipose tissue exists in 2 main compartments, but there are several others that I'm not going to talk about today. But there's the abdominal subcutaneous adipose tissue, and this actually is divided into superficial and deep compartments. And then there's the visceral adipose tissue, and this is a depot that is sitting in the omentum within the abdomen. It can secrete inflammatory cytokines that go to the liver through the through the portal circulation, and that can result in insulin resistance at a hepatic level. However, there are multiple other depots. There is the bone marrow, there's the pericardial fat, there's the perinephric fat depots, and we really don't know much about those just because of the difficulty sometimes in studying them and what they mean in a given context for an obese person. But again, adipose tissue biology, of course, and where the adipose tissue is, can determine the metabolic phenotype of a person. And that was really important for us to understand. And just to explain the risk from adiposity is that diet and many other factors can contribute to an increase in body fat. That increase in body fat can result in a chronic inflammatory state characterized by the activation of the immune system. This is something that our research group is very interested in. And that inflammation, along with many other factors, including lipid excess, can result in insulin resistance. The combination of this cycle can result in dyslipidemia, can result in altered glucose metabolism, can contribute to components of the metabolic syndrome, such as hypertension, and can also lead to sleep apnea and fatty liver and all these other complications that we see. Now, chronic illness, of course, is the end point. And we know now, of course, not only cardiovascular disease and diabetes are higher in people who live with obesity, but also polycystic ovaries, cancer rates, some cancers are higher, increased rates of gout and non-alcoholic fatty liver disease in this population also have been described. So it's a complex mix that contributes to diabetes risk. And I wanted to highlight the role of the immune system in the development of obesity and diabetes. And one of the important things to appreciate that in humans, we really focus on the adipose tissue as being the main driver of cardiometabolic risk. But the adipose tissue is in fact not a single entity, and it has multiple cell types within it that can actually contribute to adverse metabolism. But also we have to remember that there is a crosstalk between different organs that occur continuously. So the adipose tissue talks to the liver, talks to the immune system, and there's a coordination that involves different signaling cascades that regulate the metabolic pathways within humans. And if we push that back in evolution, we see, for example, in the fruit fly that we have today, and we've diverged from the fruit fly several million years ago, that the fruit fly has something called the fat body. And the fat body actually has the adipose tissue, the liver, and the immune system combined. And it is not difficult to see that in evolution, as things moved forward, organs split and became more complex, but that crosstalk is probably maintained throughout the metabolic regulation process. This process was looked at in a paper that Catherine Wang published again when she was doing her master's. And here we interrogated the fat mass and fat depots in survivors of childhood brain tumors in a longitudinal study that we're running called the CAN-DECIDE study. This study is running in multiple Canadian centers for the past 8 years. And we have about 450 kids in this study. And the key difference of this study from other cohorts is actually it has a non-cancer control population that is drawn from the general population. And that is quite a strength because many of the cancer survivorship studies use siblings, and siblings in fact have a lot of similarities to the brain tumor survivor, while this study actually using general population control. And in this study, Catherine looked at a multitude of brain tumor types. Brain tumors are fairly diverse group, but the largest group that I want to draw your attention to is something called the glioma. This constituted about half of the group, and the gliomas are relatively benign tumor. They cause the problems because of their location, but actually they're relatively benign. They're relatively easy to treat. These tumors were distributed above the tentorium and on and in the infratentorial region, almost half and half. And about 3/4 of these children had surgery, 40% had radiation therapy, and about half of them had chemotherapy. And we also had a groups that were actually just been observed. They hadn't had any treatment modality. In terms of the treatments, again, this is just a summary of the other slide. And when we looked at the endocrine profile of these children, several children had multiple endocrinopathies, including hypothyroidism, growth hormone deficiency, hypogonadism, along with central adrenal insufficiency and precocious puberty. But also we had children who have single hormonal deficiencies. Again, hypothyroidism, growth hormone deficiency, and hypogonadism being the most common ones. All these hormones were replaced appropriately for about a year before the inclusion in this study. So these children should have a normal, essentially metabolic baseline, hormonal baseline. Now, when we looked at the fat mass percentage, which we measured using bioelectrical impedance, this is a technique that's been validated against DEXA scans, and we measured the waist to hip ratio and the waist to height ratio. What we were seeing is that there was a higher fat mass percentage in the brain tumor survivors when we compare them to control. There was also a higher waist to hip ratio and a higher waist to height ratio. Now, it's important to indicate that the waist to hip ratio and the waist to height ratio measure central adiposity, but they don't necessarily tell us that these children have visceral adiposity, the one I was showing you earlier. But we know that there's a higher central fat, and we know that the waist to height ratio has been associated with more visceral adiposity. But more studies are needed to discover whether actually these kids have more visceral fat. And I would predict actually they will. But again, we don't have that evidence yet. But these children do have higher central fat. They do have higher total fat. And that was higher in girls more than boys. And then we run a principal component analysis where we wanted to find out what could predict adiposity, so that when we are seeing children in the clinic, we could actually inform families about that risk. And what we identified was that brain tumor location, hypothalamic tumors, supratentorial tumors, it trended to be positive in that regard when it comes to the total fat, but it wasn't really significant for the central adiposity, as you can see here. But total adiposity actually can be predicted where the tumor would be, and radiation therapy as well. So we have no markers at the moment to help us determine who will get central adiposity or visceral adiposity. But we know that if the tumor was in the hypothalamus and these children receive radiotherapy, that they will be at higher risk of having higher adiposity. And we know that higher adiposity can be associated with a future cardiometabolic risk. So this was really the first time we see an indication that perhaps the cardiometabolic risk profile is building early in those children. And that might explain to us the risk of diabetes. And it may then explain to us the risk of a premature mortality that we are seeing. And this is the model that we're trying to develop at this point. Now, Catherine went on to show that the children who survivors had a higher total adiposity in the order of about 4%. Now, 4% may not sound like much, but if you think of the average child having about 20 to 24% fat mass, this can translate to around 20% excess fat in the body. And if we think of this over lifespan, then we actually will start to see that this might be a problem that is actually starting early in childhood. And Catherine also was able to demonstrate in her work that the waist to hip ratio and the waist to height ratio were also higher in the order of about 6 or 7% in those children. Now, again, these are children who have survived a brain tumor within a few years. We're not talking about them in adulthood. These are still children who are building an adverse cardiometabolic risk profile early in life. Now, one of the questions we asked them, okay, there's a higher adipose mass in those kids. Does this adipose tissue function normally? Because at the end of the day, just having more fat mass doesn't really mean that this adipose tissue is not functioning normally. And from the work that we have done in the lab, really we examined, and we are continuing this work now, but we examined the metabolic profile and the adipokines that the adipose tissue produces. The adipose tissue is an active metabolic organ. It secretes multiple factors that act in an endocrine fashion remotely, but they can also act locally, and they can also act on the adjacent tissues and cells. And what we have, of course, in obesity is an imbalance between the pro-inflammatory cytokines, and there is a list of them here, and that includes leptin, IL-1 beta, TNF-alpha, and the anti-inflammatory cytokines, including adiponectin, IL-10, and IL-1 receptor antagonists, among others. This is not a comprehensive list by any means, but it is the imbalance in cytokine production that can lead to dysregulation of metabolism within the adipose tissue over time. And in this work that was done with William Jennings and Danielle Sims when she did her master's with our group, we were able to demonstrate that the adipose tissue appeared to secrete similar or at least clearly trending leptin levels that are associated with the fat mass. And this is what we had expected from the data that we have from children who live with obesity, and that leptin is a marker of the adipose tissue. It goes up as the adipose tissue mass goes up. And this correlation, as you can see here, is positive, and it is similar between the brain tumor population and the controls. And what that indicates to us that as the adipose tissue expands in survivors of childhood brain tumors, there's an upregulation of the production of leptin. And this is what is expected and what is seen in the general pediatric population as well. And an additional work that was done by Rebecca Ronsley, who is an oncology fellow who's working in British Columbia in Canada, she was able to demonstrate that adiponectin, which is an anti-inflammatory adipokine, was actually trending negatively with the fat mass. And this was similar in both populations, the control group and the brain tumor survivor group. And this is what we had expected to see based on the general population data. The anti-inflammatory cytokines decline when children start to expand their adipose tissue and become overweight or obese. So these are trends indicated to us that the adipose tissue probably is functioning normally. It might be a higher mass, but it appears to be, at least from the two main adipokines that the adipose tissue produces, that it appears to be functioning normally, but it certainly is expanding. And it certainly is expanding in multiple compartments. Now, at this point, we really know a lot about these children. We know that they are dying prematurely. We know that they're at risk of developing cardiovascular disease and type 2 diabetes. We know that in childhood, the body mass index Z-score is not a good measure of the fat mass. We are offering a promising new index for adiposity in those children, the Tripondral mass index. We have demonstrated that the adipose tissue is expanding. We have demonstrated that it functions likely normally, looking at the adiponectin and leptin. So the next question was, are there any current interventions that can help us target obesity in survivors of childhood brain tumors? And for that work, again, Catherine did another systematic review that was looking at this particular question. And this is a summary. This table, we had to adopt it just to show the main points. The treatments that have been used so far really have focused on appetite suppression, which was the main kind of idea, which I think is valid. Trying to mitigate the impact of obesity on the body by using insulin sensitizers like metformin and affecting lipid metabolism. Exenatide was used to try and suppress appetite. Octreotide is something that again is used to suppress appetite, along with dexamphetamine. All these are medications that are really the main focus of which was to try and target the obesity component by trying to suppress appetite. And the difficulty, of course, that we ran into is the number of patients per study. As you can see, the numbers are actually very small. The duration of follow-up was actually relatively short. And the only intervention that showed some promise was a non-randomized intervention that had 39 children, and it followed them up only for 1 year and put them in a lifestyle intervention program that resulted in changes in BMI. But these changes were actually not very uniform, and there was no data beyond the 1 year. And again, because of the small sample size, we did have to downgrade the level of evidence, which is a technique that is used in systematic review. And when we looked at the surgical interventions, bariatric surgery, again, the total number, as you can see here, is about 12 patients. And it's very difficult to make any conclusions or recommend these treatments on a routine basis. It certainly did result, well, gastric bypass surgery certainly resulted in a reduction in body mass index. But again, we could not recommend any of those interventions. And the reason for that is we use a very rigorous framework when we do systematic reviews to look at something called the risk of bias. And we also evaluate the quality of the evidence using something called a grade. And what you can see here is actually this data is not very helpful to advise on interventions. They're anecdotal sometimes. Sometimes the follow-up period is very short. Sometimes the cohort itself, the measurement of outcomes is not consistent, and we downgraded the level of evidence into very low, so we could not recommend any of those interventions. And at this point, actually, we are building our own interventions that we are going to start randomized controlled trials to try and improve outcomes in those kids. So these are really some of the concerns that we had about the data. Again, there was no control group, and none of them actually had randomized design, which causes, of course, problems in the intervention. And one of the final thoughts I had is to understand, why do children with a brain tumor develop obesity? and are at risk of increased fat mass. And this will be a multifactorial problem. As you can imagine, these children are precious. They have survived a life-threatening disorder, and they certainly are cut some slack when it comes to being active or focusing on eating healthy foods. And that overprotection sometimes can be problematic. Even in the schools, sometimes the kids are not allowed to be active because people are worried that they might be injured or they might have a health problem. So again, a bit of education to everybody who takes care of them is really important to try and make them continue to live a healthy lifestyle. Of course, for these tumors that impact the hypothalamus, you can have altered energy balance. The basal metabolic rate can be changed. If these children have neuropathy or coordination issues because of their surgery or radiation, they can have reduced mobility and physical activity. Radiation to the tail of the pancreas have been shown to increase the risk of diabetes because there's an increase in the concentration of islet cells that produce insulin at the tail of the pancreas. The hypothalamic pituitary damage can impact sleep, can also impact metabolism and leptin signaling and insulin signaling in the brain. Vision problems, again, because of the tumor or the treatment, imbalance, pain, mental health issues are significant in this population as well. And medications that are used to treat them sometimes, like antidepressants, can also make children gain weight. So as you can see, it's not really a one thing that you can target. There are multiple things. And that means you have to replace the hormones appropriately if they're deficient. You have to focus on a healthy lifestyle intervention that is really persistent. You have to do it all the time. You have to take care of any morbidities like vision issues, balance issues, pain issues, and all these things need to be streamlined so that these children can actually be physically active and live a healthy lifestyle. So my recommendations for teams that refer patients to us really is to focus on a lifestyle intervention that is family focused, because parents take care of these children and sometimes extended families as well. To think of behavioral interventions, including nutrition, physical activity, sleep regulation, minimization of screen time, and mental health support, which we find are really critical in this population, to try and really personalize those interventions to the specific child and family. We always recommend, of course, an aggressive management for obesity and its metabolic abnormalities, and to manage the hormonal deficiencies that might arise and to screen for them on a regular basis. And we do believe that there's an urgent need to test high quality interventions in this population to try and manage adiposity, and hopefully we can prevent long-term impacts of the disease. And then I want to leave you with this thought, is whether we can actually prevent obesity and type 2 diabetes. And there's talk about this in the literature. And we had a group meeting and a meeting that had a focus group approach to it. And Raja Balakumaran, who was a student with me at the time, did this work. And basically, the audience composed of patients and families and students and healthcare providers, again, tried to fit the interventions into domains which include nutrition, physical activity, sleep, and mental health. But we really tried to operationalize it into what is the process, what is the content of the process, and what are the outcomes that you want to measure. And the summary of that is you need a multi-pronged approach that involves multiple stakeholders, including anything from government and down to schools like teachers, friends, healthcare teams coming together, using different tools to try and affect a positive outcome. And we felt very strongly that these outcomes needed to be simple, not necessarily always technological, although technology had a role. We needed to destigmatize obesity and making sure that children can actually access those services. We needed to make sure that we can build the skills within family, because we, again, don't believe that hospitals are the right place to manage obesity and adiposity. These needs to be community-based interventions. We needed to personalize it, because as I showed you, different kids will come to us with different abilities to do things. We didn't feel, again, this need to be hospital-based, and we wanted to make sure that the education and knowledge that we provide are of such a quality, but also that needs to be evolving based on the new knowledge that is available in the literature. So in summary, I hope that I have convinced you that these children have a higher risk of type 2 diabetes than controls, and that excess adiposity may be an early risk factor for the adverse cardiometabolic disorder in this population. And currently, there are no high quality interventions to manage adiposity in this group. And this is something that we're looking at actively at this point. And I wanted to acknowledge the different people that have contributed to this group. There are multiple graduate students that have helped us with this work, and undergraduate students. We collaborate with several faculty across the country and around the world. And we have several people in our lab work that have helped us. My research program is translational, so I have a wet bench component to it that involves using human biological samples to understand the metabolic pathways that regulate the risk of diabetes and obesity. And we have also the clinical arm of the project, which some of this data that I showed you about really bridge both domains. And we have, again, to offer great thanks to multiple collaborators that made this work possible. And I also want to thank the funders for allowing us to do this work. So I'm going to stop here, and I'm happy to take any questions that you might have. And I want to thank you very much for your attention.
Thank you, Dr. Saman, for your excellent presentation. It was really a privilege to hear from you, and I'm sure all of us listening would have got new insights in this area. So we've got a couple of questions as we move on to the question and answer session. First question would be, after which modality of therapy is adiposity most commonly seen in this group of children?
Sorry, I didn't get that question. Just could you repeat the
modality of therapy? Is it surgery or radiotherapy, or after which modality do we usually see the adiposity commonly occurring?
Oh, yes, that's a great question. So the majority of these children, as I've shown, have surgery. And then the second most common modality is radiation. What we have seen is the combination of surgery and radiation are probably being important, but the biggest one is radiation. Radiation and what I'm talking about here, I'm talking about cranial irradiation, radiation to the brain, or craniospinal irradiation. These two modalities appear to be associated with the highest risk.
We've got one more question. When would you suggest that we start monitoring a person with who is the childhood brain tumor survivor? How to follow up?
Yeah, that's a great question. You know, I say this to my neuro-oncology colleagues all the time, is that because survival has become so prevalent, you know, sometimes 70 or 80% of these children are surviving their brain tumor. I had proposed to them that the second visit after they see the neuro-oncologist is actually to come to see the endocrinologist. And so my ideal world would be actually you intervene at the start, you intervene consistently, you intervene aggressively, and you continue to intervene beyond the cure of the brain tumor and try and build a skill set in the family and the child to take those you know, skills forward, to live a healthy lifestyle, to try and mitigate some of the risks you know, of their treatments and of the tumor. That's a great question. And I have this debate all the time with my colleagues. I haven't been successful so far in seeing them very quickly after the diagnosis, but we typically see them 6 months after the completion of a treatment. And that's actually the criteria for recruitment for our studies. But yes, I think the dialogue is continuing on when actually we should be involved, because I do feel we need to be involved very early. Great question.
Thank you, Dr. Samad. Another question is, the present Endocrine Society guidelines on pediatric obesity do not have any major recommendations for the survivors of childhood cancers. Do you think any changes should be made in that?
Yeah, that's a great question. So the guidelines, I mean, the brain tumor survivors in particular, you know, are a bit different than the regular obesity group, because they have risk factors that are built in because of the anatomical location of the tumor or the treatments that come through. They don't really, you can't just use the regular guidelines, you know, just say, oh, you know, just nutrition, physical activity. You have to modify everything. For example, we have children who can't coordinate movement. So if you say exercise, you're causing a major injury risk. They could fall, they could hit their head, get a head injury now. And now where do we go? So you have to really modify and personalize the intervention in a way that involves multiple resources. And these needs to be kind of designed in a way that are sustainable depending on your healthcare resource system availability. And they need to be persistent. So that's expensive work to do. So the guidelines really don't touch specifically on the brain tumor population. The children oncology group has some guidelines, and this is a group that follows these children as they kind of survive the tumor. Again, the guidelines are not very specific. They speak a little bit more about, again, nutrition, physical activity, etc. But we're actually moving in a different direction, I'd say, within our group. We're moving into more active interventions. We're moving more in the direction of pharmacotherapies. We're moving in the direction of virtual interventions, and that actually has been just heightened with the pandemic. We don't believe there's a lot out there that actually can help from a guidance perspective. And I agree, there needs to be some revisitation of these guidelines. And this is work that we're doing at the moment in collaboration with our colleagues. We're developing those new interventions, and we'll be rewriting those guidelines once evidence become available. The problem at the moment, there is no evidence, so you really can't recommend, anything beyond what's available. And as I've shown you, there isn't really a whole lot of evidence that you can actually use to take care of these kids.
Thank you, Dr. Just one more question, slightly off from the topic. How comfortable are you using HbA1c for looking at dysglycemia in children?
Yeah, that's a good question. So we don't really use it for diagnosing diabetes or pre-diabetes. We use it to monitor existing diabetes. And that's a very, very good question, because even when you look at guidelines, it's really, there aren't many tests that you can use to monitor those kids and kids in general. Fasting blood glucose has been proposed as probably the most sensitive. OGTT has only 30% reproducibility in children, so you have to repeat it at least twice before you can get a real answer as to the child having diabetes or pre-diabetes. But A1C is not used really as a diagnostic tool. It's mostly a supportive tool beyond diagnosis.
Thank you, Dr. Samad. I think we don't have any more questions remaining. Thank you for agreeing to be with us this evening, and thank you for excellent presentation, also for taking all the questions. I think now I will hand over to Dr. Jacob for closing this session. I hope all of you had a really wonderful session, especially all our students and residents who are watching. And thank you so much, sir, for that wonderful talk. It was really an eye-opener. We were glued to the talk, actually. And we are extremely grateful for coming over and sparing your very precious time with us on this platform. Thank you so much. Justin,
it's my pleasure, Jacob. Again, thank you very much for inviting me. I really appreciate the opportunity, and I hope again that the group has learned something about how to take care of these children. So thank you again for the invite.
Absolutely, sir. And if you visit India ever, we would like to host you at our institution. It would be great to have you at our institution.
I would love to. Thank you.
And also, I would like to thank our moderator also for coming over and moderating this session admirably. Thank you so much, Dr. Justin. And before we close, I would like to thank all those who have participated also and listened to this wonderful session. Until we come back to you with yet another session, we are signing off from Believers Church Medical College and Hospital. And once again, I would like to very specially thank our speaker for the day, Dr. Constantine Saman, for that wonderful talk. We are extremely grateful to you, sir.
Thank you very much again for the invite. I appreciate it.
Thank you.
Have a great day. Take care.
Have a great day to you. Thank you so much.
Bye-bye.